Thank you so much for the kind introduction. Very well-planned program. So from the third trimester growth, we now come to another aspect, which is evolving anomalies in the third trimester. I would like to especially thank Jagruti, my very dear friend. This looks like a TTTS slide, if Vandana ma'am is here, where of course I'm the recipient twin. And we move on to the topic, which is evolving anomalies in the third trimester. And probably at the end of this topic, we could answer this question, whether we really need to do a third trimester or not. So this whole session would help you answer that. It started in very early 1993 when the New England Journal of Medicine said that screening ultrasound did not improve any perinatal outcome. So this is how it started. Let's see how it's changed over the years. Then a paper came which said that the role of routine ultrasound is to improve outcomes is disputed. So at least they started considering that antenatal ultrasound needs to be done. And now we have come to a stage when 2011 we have the FOXY guidelines on the Internet of FOXY, which are the guidelines on use of ultrasound in pregnancy. And we now know that it is extremely important to do an antenatal ultrasound to detect birth defects. Now all of us here are obstetricians, sonologists, fetal medicine specialists, but we all think with the same brain. And unless we know it, we cannot look for it. This talk has particularly been made for the obstetrician and the fetal medicines, considering that the diagnosis has already been made, and now what next to be done with it, because the diagnosis per se radiologically is extremely easy in the third trimester anomalies. We've been hearing about this old pyramid of care being inverted and the 12 weeks being extremely important, but let us now for a change see what we can see in the third trimester. And these are ugly surprises because everything's going fine. As fetal medicine specialists, we agree that growth scan aaya to we are relaxed. Let's just finish it off in 5 minutes because we just have to see the Doppler's growth and the AFI. But there are some surprises that we see here. And therefore, here is the role of late antenatal diagnosis. Why do we need it? If we find a problem on the third trimester scan, we need to counsel the couple regarding the nature of the anomaly, the implications on survival, the need for postnatal intervention and the nature of interventions required, the long-term outcomes, quality of life, and really important is the finances which would be associated with the treatment behind this problem. It is a multidisciplinary approach. Decision regarding time, place, and the mode of delivery depends upon this diagnosis, and a holistic perinatal management is required. What are the components of a third trimester ultrasound? Ma'am is just briefed. She spoke about these. Let me just add the two most important ones, and it's just the structural check. And why so? 40% of structural defects can be diagnosed in the first trimester. You can add on another 35% on the anomaly scan, and as many as 15% in the third trimester. So this is almost equal to what you can see on the anomaly scan, and that brings it to around 95% antenatally. Here we are today getting squashed between MTP and PCP and DT, and we can no more get away by saying that it's okay, now it's 20 weeks, ab diagnose karke bhi kya karna hai because we can't terminate. No, we can terminate. Even at 35 weeks, you can go in and say that I do not want this baby. It's through the court. It's not a tiring effort. It does not involve too much finances, and it is possible to terminate such babies even after 20 weeks. Here is a checklist of what we must see on the 19 weeks scan, which is the anomaly scan. And let us now go to what we must see on the third trimester scan. So I've actually highlighted the ones that you should definitely see structure-wise on the third trimester scan. The skull, head and brain, stomach, GIT, diaphragm, kidneys, and the transverse view of the spine at least. What you cannot mostly can see on the third trimester is the extremities and the tip of the spine, because sometimes it could become very crowded, especially if the amniotic fluid is on the lower side. And what you could see, depending on the position of the fetus, is the face, heart, and the spine, depending on what the fetus is showing us. There are three kinds of defects which we can see in the third trimester. One is the ones you've missed it. It was there on the anomaly scan, but you couldn't pick it up. Another is they have progressed. So for example, agenesis of corpus callosum was always there, but it was more difficult on the anomaly scan. Ventriculomegaly, it was there, 11 millimeters, it's now increased to 15 millimeters on the third trimester. But the evolving ones which could not have been seen on the anomaly scan, like microcephaly, is something which we see for the first time, and this is a huge list of those. I've tried to simplify this. The commonest one, stomach bubble not visualized in the third trimester scan. What do you do next? Wait for 15 minutes, call her back. It's mostly always seen. If still not seen, you check for the amniotic fluid. If the amniotic fluid is reduced because of a leak or because of any other reason, that's because the baby is not able to swallow the fluid and therefore the stomach bubble is not seen. If the amniotic fluid is increased, so polyhydramnios with absent stomach bubble, you have esophageal atresia, facial clefts which make it difficult for the baby to swallow the amniotic fluid, and of course contractures and the fetal akinesia sequence. If the amniotic fluid is normal, then it could be a CDH. Of course, in late CDH, there would be polyhydramnios as well. Now, can esophageal atresias be missed antenatally? Because as soon as you come to the third trimester, you see polyhydramnios, you start searching for the stomach bubble and think if it is an tracheoesophageal fistula. So these are the types. It's not theoretical. We need to know this to find out if we can really miss it and get away in the court. So these are the types of, the pink one is the esophagus, the blue is the trachea, and this is the stomach bubble. The first one, there is no fistula. It is pure esophageal atresia. Second one has a tracheoesophageal fistula. The third one has a fistula between the trachea and the stomach. So can you see the stomach bubble there in the third one on scan? Yes, you will, because the tracheal secretions would go to the stomach and give you a false positive stomach bubble seen on the scan, whereas there is still an esophageal atresia there. Similarly, in the last two types, and unfortunately for us, the commonest one is where you can actually see the stomach bubble. So always remember, if you're seeing polyhydramnios which is unexplained, the BSL is normal, and you see a small stomach bubble, or even if you see a okay normal stomach bubble, do not forget to write that postnatal evaluation for an esophageal atresia or a TOF is required, because this cannot always be picked up on an antenatal scan. Okay, so esophageal atresia, you look for a small or absent stomach bubble with polyhydramnios. There could be a blind esophageal pouch, difficult to demonstrate, but if seen, extremely specific for esophageal atresia. If fistula is present, we do not see a blind pouch sign, we just saw that. Okay, you need to do serial USG. If the mother is getting discomfort, you need to do an amnio drainage. Try to take her as close to the term once you've established that the karyotype is normal, because 20% of these would have associated chromosomal problems, and it warrants an amniocentesis irrespective of the period of gestation when you have diagnosed it. Coming to bowel atresia, there are three types: duodenal, non-duodenal, and large bowel atresia. You need to rule out underlying aneuploidy. So as soon as you see a dilated bowel loop, it is not supposed to be normal. Okay, duodenal atresia. So you need to see that there is polyhydramnios with a double bubble sign, extremely easy to diagnose. You cannot miss this one. You need to do serial USGs again to drain out the amniotic fluid. Underlying trisomy 21, 30%, this still warrants a amniocentesis irrespective of the gestation. Now these would mostly never come up on the anomaly scan. You're really lucky if you get this on the anomaly scan. Even when you get it at 30 weeks for the first time, you can do an amniocentesis for her and declare that the karyotype is normal, because if this is an isolated finding in a chromosomally normal fetus, it has a good prognosis postnatally once the baby is operated on. Now coming to the small bowel loop dilatation, you see dilated loops with polyhydramnios. Here are your DDs. You have either bowel atresia or stenosis, or there is a malrotation with volvulus. There could be meconium ileus, total colonic aganglionosis. These are extremely difficult to differentiate on ultrasound, but what basically it's all heading to is they would need surgery. And most of them which are isolated in a normal chromosomal pattern in the fetus do well postnatally unless they are seen at multiple levels. Okay, here are some hints on the level of polyhydramnios that you can decide what kind of obstruction it is. So if there is a more proximal obstruction, there would be more polyhydramnios. So more proximal the obstruction, more would be the amount of amniotic fluid. Enlarged stomach plus polyhydramnios plus dilated loops. If you see dilated loops along with a big stomach, it's usually a jejunal atresia rather than an ileal atresia. If there is a colonic obstruction, there is usually no bowel dilatation, because most of the water has already been reabsorbed by the time the meconium is reaching the large bowel. So coming to small bowel obstruction, the same thing. Something new in this is 10% of them could be cystic fibrosis. So again, you may not check the couple for a carrier status late in pregnancy because you would be very late. The baby could deliver by then, but you need to keep in mind in your report that this needs to be checked postnatally here. Meconium peritonitis, if it is simple peritonitis, the outcome is excellent and the risk of cystic fibrosis is extremely high. So in a fetus with no cystic fibrosis but simple meconium peritonitis, it has got an excellent outcome. The reason why this was being put up is you need to do an in utero transfer to a tertiary care center where there is an ICU, a pediatric surgeon would be involved immediately prenatally, and everything is in place for this baby to be taken care of as soon as it's born. A few abdominal cysts. We know the fetal abdomen is Pandora's box. I've tried to simplify it as much as possible. If you see a cyst in the upper right quadrant, it could either be a hepatic cyst or a choledochal cyst. In the left upper quadrant is a splenic cyst. A posterior one is renal. It's easy to make out because it would be connected to the renal tissue of the fetus. Anterior mid-abdomen, the midline structure cysts are mostly mesenteric or the umbilical vein varix. Extremely easy to differentiate because as soon as you put in color, this is the only one that will take in color. The lower abdomen cysts could be ovarian cyst, the commonest one, uretrocele, urachal cyst, and hydrometrocolpus as a part of a cloacal abnormality. Anywhere, if you cannot make out what's going on, one differential diagnosis that you have to give is an enteric duplication cyst, which would never be confirmed unless you postnatally evaluate the fetus. So ovarian cysts are not always benign. That's why I put this up. Usually what we put in is, we cannot write it's an ovarian cyst because of the PCPNDT laws, but you need to put in a differential as an ovarian cyst. And why you cannot always get away with them? 50% will regress spontaneously, but 35% could show torsion and hemorrhage, especially if they are big ones, and 25 to 30% could require surgery. So you cannot always leave them alone. Depending on the size, less than 5, most of them regress. More than 5 centimeters could have complications and need follow-up. So don't believe that ovarian cysts, just leave them alone and they are excellent and just because of a hormonal effect of the mother and would go away after birth. This is what we need to follow up in them. And this is an umbilical vein varix, very clearly seen. We cannot miss this. So any cyst you see anywhere in the brain, in the thorax, in the GIT, the first thing is you put in color and you look for peristalsis. So that's how you can distinguish, have an idea of what organ this is coming from. So varix, the only tricky thing is that, of course, it could be associated with a fetal growth restriction, but it could have a sudden thrombosis, which is unpredictable, and this could cause an IUFT. So once you diagnose a varix, do put in a line for surveillance of the fetus. Some even deliver electively at 36 weeks because there is no advantage of pulling them further and increasing the risk of sudden stillbirth. You also have to look in for a hyperdynamic circulation because of the varix, which can give rise to hydrops. So hydrops, thrombosis, and IUFD are 3 deadly but fortunately rare complications of umbilical vein varix. Diaphragmatic hernia, another very interesting thing that we keep talking about and seeing. Now, either the stomach, liver, or the bowel could be in the thorax. Easy to diagnose. Always make sure you are looking at the diaphragm when you are doing an third trimester scan, because this is something that would very commonly present only the third trimester and sometimes even postnatally. Left is more common than right. Polyhydramnios is usually seen after 26 weeks. All of us who scan know that we now calculate the LHR ratio, which is the lung by head ratio. We need to know that these ratios are calculated for the contralateral lung. Okay, so if it is a left-sided congenital diaphragmatic hernia, you presume that the left lung is already compromised. So what you need to then measure is the right side, the functionality of the lung, and prognosticate accordingly. You need to have a pediatric surgeon in loop and deliver where there is an NICU setup. Can I get just 1 minute?
Well, you still have 2 minutes.
My presentation just went off. Thanks for this break, Jagrati. I can't. Okay, yeah. Now, another tricky thing that we see, borderline ventricles on the anomaly scan, 9-10 millimeters, we are confused. Always mention a line on the report of the anomaly scan. The progression of ventriculomegaly cannot be predicted at this gestation. If it does not progress, it is excellent prognosis. If it progresses, the prognosis could worsen. So look at these bad ventriculomegalies here, which would have a very poor neurodevelopmental outcome, of course. We know that once you see a ventriculomegaly at any gestation, you need to have this workup. I would not go into the details. We have even a panel coming up which would enumerate a few of these. Okay. borderline ventriculomegaly, excellent paper in the White Journal which says despite an isolated borderline ventriculomegaly, 10 to 13% of them would still have a neurodevelopmental delay in some form or the other. So this needs to be kept in mind. Now coming to some of the important things in the third trimester. Microcephaly, extremely poor prognosis. Why I put this up? Do not try to resuscitate the baby. Do not try to perform operations, especially when the standard deviation of the head circumference is more than 3 less than what is expected. Okay, so the worse the microcephaly, the poorer is the outcome. Megacisterna magna as an isolated finding, excellent prognosis. Okay, so if you see a large cisterna magna, even 12 to 13 millimeters, but everything else looks good, the cerebellum and the vermis is fine, you can leave them alone and do not follow up them, increase the anxiety. These are some uncommon ones with extremely poor prognosis. The reason to put them up is do not try to resuscitate and go ahead and do a lot of expensive surgeries on them. Cerebellar hypoplasia we would have diagnosed already. Okay, last is the renal system. So kidney, of course, very mischievous. We all know we could have very normal kidneys on the anomaly scan and still see the dilated renal system on the anomaly scan. These are the differential diagnosis. But something good about the kidney problem that is seen first time in the third trimester is that it's usually not as severe, because if it would have been severe, we would have got a hint on the anomaly scan. So most of them do well. Isolated unilateral hydronephrosis, leave them alone. Do not do, you don't need to send them to a tertiary care for delivery, but you need to keep a follow-up because you don't know what the reason for that isolated hydronephrosis was. Unilateral MCDK, very commonly find unilateral renal agenesis and multicystic dysplastic kidney. They have excellent prognosis, but do not reassure that we all need only one kidney to live, because 30% of them will have a contralateral kidney vesico-ureteric reflux which may scar the kidney. So you need to follow them up. Achondroplasia, ma'am has already mentioned, first time seen in third trimester, has got good prognosis. Find out if the parents are carriers and you can do a prenatal diagnosis in the next pregnancy. To summarize, improvements in neonatal care and the pediatric anesthesia have led to improved outcomes of structural congenital anomalies. Associated anomalies influence the outcome in the long-term morbidity. Antenatal diagnosis, even in the third trimester, helps in planning the mode of timing delivery, counseling regarding the postnatal plan of management, outcomes and the finances for the couple. They are precious babies, the parents are educated, so you need to give them informed decision making. So once you have the diagnosis, you counsel for the prognosis. Will you protect a preterm birth? You know there is an esophageal atresia, you've done a karyotype, you know there's a problem. Will you still stop a preterm birth? You will not. Will you still take her to an NICU? You will not. So you know the prognosis of such babies. Will you do a cesarean? You will not do it for her. So all of us together can help to have these happy babies being born together in this world. And thank you so much for the opportunity and for the extra time as well. Thank you.